Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors, Samuel Rouleau, Megan Hilbert, Doug Wallace, Caitlin Nicholson, Michael Stoker, and Clay Smith. Okay, the first article, which is a good one, ultrasound-facilitated catheter-directed thrombolysis for acute pulmonary embolism out of the New England Journal of Medicine. This is the kind of article that I've been waiting for. Is it? Not quite. It's really, I'm actually very disappointed by this. I have been waiting for trials to come out that, really justify the use of catheter-based, strategies for the management of pulmonary embolisms. And this was almost that, but it wasn't quite that. I thought they were going to gloss over it in the introduction, but they do indeed point out that there is no evidentiary support really for catheter-directed treatment versus usual care. And I will give them a little bit of credit that they were very upfront about the sponsors of this trial, which is, of course, appropriate, and it's something you have to keep in mind that this was, of course, industry-driven. So what is this trial? This was a group of PE patients who had RV strain and might have benefited from some kind of reperfusion therapy instead of possibly just anticoagulation, but was not the slam dunk group of patients who's very high risk who would definitely need thrombolysis. So you're really sort of low down on the spectrum here. But you're still patients who definitely could benefit because they've got some RV strain, they've got some abnormalities in their vital signs. And this was a randomized controlled trial of 544 patients pitting anticoagulation alone versus catheter-directed thrombolysis in adult patients with, as I said, with sort of intermediate risk PEs, although now we're moving away from those terms. And as you might expect from an industry study, we've got a composite outcome, which is the 7-day occurrence of PE-related death, recurrence of PE, cardiorespiratory collapse, which is defined as cardiac arrest, new shock, ECMO intubation, or a new score more than 9. Now, the primary outcome only occurred in 11 patients in the catheter-directed thrombolysis group versus 28 patients. That's 10% of the anticoagulation alone arm. And so that all by itself seems like, hey, we're actually doing much better with thrombolysis. However, the difference here, remember this is a composite outcome, was really just driven by difference in the news score. And I don't really care about differences in the news score very much. If you just look at how many deaths there were, then there were more deaths in the catheter-directed thrombolysis group at both 7 days and 30 days, without any difference in intracranial hemorrhages or other real side effects that we care about. Also, I always hate to see this. How many intermediate risk PEs do you diagnose in your emergency department per year? Is the number 18? That's roughly every 3 weeks that you would get a diagnosis from your emergency room. And that's just how many were screened in this study between the various sites. So you only screened one patient every 3 weeks. That's not a lot of pulmonary embolisms. And enrolled was just 2.3 patients per site per year. That's really seems like not a lot. I know trials are hard, but this always smells to me like cherry picking in some way. Also, unfractionated heparin was the most commonly used anticoagulant in this study, 72% of the intervention group, which is a shame because it's just not the best thing that you could be anticoagulating your patients with. So we might actually expect here that in the real life setting of patients using low molecular weight heparin, as you should be doing, that the catheter-directed thrombolysis group would be doing even more poorly compared to anticoagulation alone. And then really down the line, did anyone get systemic thrombolysis afterwards? Were there significant differences in the downstream management of these patients, sort of as you go and follow them in progression, yeah, actually the same amount of patients required rescue care as decompensated. And that's because it's really just how you define who is decompensated as to who to decide to get systemic thrombolysis. But all the same, in that case, we see more patients getting systemic thrombolysis in the group that was just getting anticoagulation alone. But as we said before, they still did fine. They still did well. This was not a failure per se because these patients are doing great. And functional status even of these patients down the line was the same in both groups. So it's all why we don't like composite outcomes. They really make these trials a little bit harder to interpret because in a lot of ways, this looks like a positive trial for catheter-directed thrombolysis. This was not really a positive trial. It's going to be labeled as a positive trial, but it was not really. And that's part of why I don't trust open evidence, because if you just read a trial like this, or it's incorporated from open evidence, which is just the AI tool that also uses a couple of big popular journals, then you get the incorporation of a lot of spin that the authors get to write into it. Anyways, that's just a tangent in me not trusting AI in every way. AI is a great tool, but it's not always the best. So you need to be able to learn and interpret studies on your own. All to say, if you are looking for real evidentiary support for catheter-directed thrombolysis, you're not really finding it here. In a spoonful, it's weak, but perhaps some patients may benefit from catheter-directed thrombolysis when otherwise they would just be treated with anticoagulation. Though it doesn't seem to be saving any lives, any days of hospital admission, or really anything else, so what are we really doing it for? Okay, then let's skip to the third article, titled Comparison of 8.4% sodium bicarb versus 3% sodium chloride in severe hyponatremia, a retrospective cohort study out of the journal Academic Emergency Medicine. Now, of course, we've got a whole bunch of different ways that we can possibly treat hyponatremia. Really, if it's severe enough, you just got to give them a load of sodium. And that's just the way you have to do it if it's severe enough or they have severe symptoms. And how you give it, well, I'm of the opinion that it doesn't really matter. You've got a bunch of different options. 3% sodium chloride is probably the most common. But, there's definitely hyper concentrated products which exist in different places of the world, which are up in the 20s for percentages. And sometimes, it takes some time to get hypertonic saline to the bedside. Sometimes it has to be prepared. However, there is one option which is pre-prepared. It's in all your crash carts, and it's something that's readily available and that most people are quite familiar with. And that is an amp of bicarb. And if you look at the amp of bicarb that you can use typically for a lot of different things, well, it has a very high concentration of sodium in it, 8.4% sodium bicarb. And so this could be a treatment possibility for severe hyponatremia because it's just something that you've got on hand. Now, this was a 2-center retrospective study which compared 42 patients with severe hyponatremia. And they wanted to compare which of these patients had an increase in their sodium level by formula equivalents, and if this was being done better by giving 3% hypertonic saline, 100 milliliters, or 1 amp of hypertonic bicarb, which is just 50 milliliters. And what we see here is that nearly half of the patients that got bicarb actually got the target of a 4 milliequivalent increase in their sodium, compared to just 10% of the hypertonic solution group. And this might sound like it means something, but if you do the quick and dirty math here, then 3% 100 mLs versus 8.4% 50 mLs, well, obviously you're giving more sodium with the bicarb. So yeah, I would expect, if you're not comparing apples to apples necessarily, for it to be better if you just give more sodium. So if you just increase the dose of the hypertonic, had we given 150 mLs, would you see any difference? Which would be a very reasonable thing for you to do. So I don't think that this necessarily justifies you picking hypertonic bicarb instead of just normal 3% as your go-to solution for treating hyponatremia. This is not a guideline recognized treatment. However, logic would dictate it's a perfectly reasonable one if all you've got on hand is bicarb or you just want to treat it really soon, really quickly. I think that hypertonic saline is going to do just as good a job. You just actually have to give enough of it in order to do that job. I do appreciate that there's a study on this now. It kind of drives the point home, though, that it's an option. You can do it. It's valid. And I like having options. In spoonful, sodium works no matter how you give it for hyponatremia, be it hypertonic saline or hypertonic bicarb. Okay, that's all the articles from this week. Let's do a quick wrap up of what we talked about. From the first article, catheter-directed treatment of PEs has really not yet proven itself, not even with this trial. This trial did see fewer patients who were decompensating, but numerically more were dying. And of the outcomes that we actually care about, we didn't see any significant difference. And that's with the patients not being ideally anticoagulated, that is with low molecular weight heparin in the sort of control arm. Then from the third article, just as we suspected, what matters most is how much sodium you give to increase a patient's sodium level, and not necessarily how you give it. That being said, this article does justify the use of possibly considering hypertonic bicarb as a treatment for severe hyponatremia. It'll do the trick. Now, if you're hearing this right now, then you are not a part of the members feed and you missed 3 articles from this past week. What did you miss? What were they about? Well, we looked at POCUS to predict whether or not you had an empty stomach prior to emergency sedation. Then we looked at what is the best drug for status epilepticus in children. And finally, can you use peripheral pressors even pre-hospital? I'm not sure. Now, links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.